Phosphodiesterase Type 3 inhibitors, also known as PDE-3 inhibitors, are medications that block phosphodiesterase 3, also known as PDE3. PDE3 is an enzyme with two subtypes, PDE3A and PDE3B. PDE3A is primarily located in cardiac cells, arterial and venous smooth muscle, and platelets, while PDE3B is primarily located in adipose tissue, or fatty tissue, the liver, and the pancreas. While both PDE3A and PDE3B are inhibited by PDE3 inhibitors, it is their effect on PDE3A that is clinically significant. PDE3 normally breaks down cyclic adenosine monophosphate, also known as CAMP, a secondary messenger molecule that is crucial for signal transmission within cells. By inhibiting PDE3, the breakdown of CAMP is reduced, leading to increased levels. Elevated levels of CAMP in cardiac cells enhance intracellular calcium cycling, leading to a stronger contractile force in the heart. This makes PDE3 inhibitors positive inotropes. Additionally, this increase in CAMP also increases heart rate. This makes PDE3 inhibitors positive chronotropes. Elevated levels of CAMP in arterial and venous smooth muscle cause vasodilation, or the widening of blood vessels caused by the relaxation of the smooth muscle. This leads to decreased vascular resistance and blood pressure. Because PDE3 inhibitors function as both positive inotropes and vasodilators, they're often called inodilators. Finally, elevated levels of CAMP in platelets cause a decrease in platelet activation and aggregation. This means that the platelets become less sticky and therefore less likely to form clots. The most common PDE3 inhibitor is Milrinone. However, there's also Amrinone, also called Inamrinone, and Cilostazol. PDE3 inhibitors, such as Milrinone and Amrinone, are used for short-term treatment of acute decompensated heart failure. Long-term use of these medications should be avoided due to an increased risk of mortality associated with prolonged use. These medications improve cardiac output, or the volume of blood the heart pumps per minute, through two mechanisms. Their positive inotropic effect increases stroke volume, or the amount of blood ejected from the left ventricle in one contraction, while their vasodilatory effect reduces afterload, or the resistance the heart must overcome to pump blood out. Milrinone is also used to treat cardiogenic shock for the same reasons. Cilostazol is used to treat intermittent claudication, which is the painful cramping experienced in the legs, especially while walking, that resolves with rest, due to peripheral arterial disease. Due to Cilostazol's vasodilatory and antiplatelet effects, this medication helps improve maximum walking distance without pain, thereby enhancing quality of life. The adverse effects of PDE3 inhibitors include supraventricular and ventricular arrhythmias, such as atrial fibrillation and ventricular tachycardia, palpitations, hypotension, headaches, thrombocytopenia or low platelet count, diarrhea, and nausea. PDE3 inhibitors should generally not be used with severe cardiac outflow tract diseases or heart conditions that obstruct blood flow from the ventricles to the major arteries, such as severe aortic stenosis and severe hypertrophic obstructive cardiomyopathy. During therapy with Milrinone or Amrinone, heart rate, blood pressure, and continuous telemetry should be monitored. Additionally, measuring cardiac index, pulmonary capillary wedge pressure, or PCWP, and central venous pressure, or CVP, may be necessary. Routine 12-lead ECGs are also generally required to monitor for arrhythmias, as life-threatening arrhythmias can occur. This risk is particularly elevated in patients with a history of arrhythmias, electrolyte imbalances, abnormal serum digoxin levels, or those with vascular catheters, which can irritate the endocardium, or the innermost layer of the heart wall. Additionally, it is crucial to assess intake and output, weight, and edema, and to auscultate the lungs. This assessment will help determine the response to treatment in patients with heart failure. If during treatment with Milrinone or Amrinone, a significant drop in blood pressure occurs, the infusion should either be slowed down or stopped, and the MRP should be notified immediately, as this could indicate toxicity. And with the continuous Amrinone infusion in particular, it is important to monitor for tachyphylaxis, or the rapid development of tolerance which typically occurs within the first 48 to 72 hours of treatment. It is also crucial not to confuse Amrinone with amiodarone. On the other hand, individuals receiving Cilostazol should be evaluated for intermittent claudication and walking endurance, both before and throughout treatment to assess their response. However, it may take 1 to 3 months until improvements are noticeable. Additionally, due to Cilostazol's antiplatelet effects, it is important to monitor for any signs of bleeding, such as bruising, petechia, or pinpoint-sized red, purple, or brown spots on the skin, bleeding gums, hematuria, or blood in the urine, and melena, or black tarry stools, due to bleeding in the gastrointestinal tract. When taking Cilostazol, you should be on an empty stomach for optimal absorption. This typically means taking it 1 hour before or 2 hours after a meal, and grapefruit should be avoided, as it can inhibit the enzyme responsible for breaking down Cilostazol, which can result in higher blood levels of the drug, increasing the risk of adverse effects. While receiving treatment with a PDE3 inhibitor, some routine blood work is generally required. With Milrinone and Amrinone, this typically includes an electrolyte panel, as abnormal levels such as hypokalemia or low serum potassium can increase the risk of arrhythmias. And Cilostazol may require periodic complete blood counts, or CBCs, to monitor platelet levels for thrombocytopenia. I hope you found this video helpful. If you did, please let me know by giving it a thumbs up, subscribing, and leaving a comment below. Thank you, and bye!